Good morning, everyone. We are here with episode 6 of When Is It About the Patient? And today we have a subject matter expert guest. Michelle O'Brien has graciously agreed to come on. So I have Carrie Burmeister, my co-host. I'm Christine McMahon. And with that being said, we're going to get started and talk to Michelle about pharmacy. So first of all, Michelle, what education is needed to be a pharmacist?
Sure. So usually it's either a 6 or an 8-year program. So at least the school that I went to, the University of Toledo, so they do a 4-year and then you have like a 2-year graduate program after that. But a lot of programs are either, we call those like 0 to 6 programs, or you can have a program where you would have like a 4-year undergraduate degree, and then that would transition into a 4-year pharmacy degree. So kind of just depending on each one, but the curriculum is usually heavily involved as far as like your basic sciences at the beginning, then you kind of move into like your med chem, your biochem kind of classes before you hit your real therapeutics classes. And then your last year is mostly clerkship. So you'll do 8 to 9 rotations out at various sites so you can see different types of pharmacy then before you hit graduation. So then after graduation, you can either head towards the residency route or towards practice route. So pharmacy residencies are 1 or 2 years, depending on kind of whether you want to hit a specialty or be more general. So you can learn more inpatient medicine or outpatient medicine during your residency year. And then your second year is more focused. It might be something like cardiology or ambulatory care or oncology if you want to get into like specific areas of practice afterwards.
So what does your typical day look like where you're at, Michelle?
Yeah, so I work in an outpatient clinic. So I get to do what we call like ambulatory medicine, but I also have a lot of learners with me, which is an equally important part of my day-to-day job. So what I do is mostly focusing on like chronic disease states. So getting your patients kind of controlled on disease states like diabetes or heart failure or hypertension. So my main focus is diabetes management because we know that's on the rise, and it really takes a multidisciplinary team to help our patients between what they can see with the physicians and then the medications or maybe some dietary adjustments that I can kind of help out with. So a lot of what I do, is in the outpatient setting. I also help a lot with medication affordability, which I know we'll touch on a little bit more moving forward. But right now with the price of medications, and especially with a lot of our Medicare patients, it's really hard to get the best meds for them. So I do kind of a lot of help with getting that more affordable for them, or finding alternative routes to get the medications that they need. And then, so that's kind of what I do, just a little bit of what I do, but yes.
I have a quick question on the affordability. So I have looked at Mark Cuban's, I'm sure you've heard of it, his cost plus drugs. I don't know if you ever refer anybody to that, but I have went out there and priced the medications that I personally take, and I cannot believe the significant difference in cost.
Yeah.
So as you approach those golden years of retirement, you're going to be on Medicare and maybe you don't have Part D. I look at it and I say, well, with his plan, I can afford my medications. I don't really need prescription coverage. But I mean, how do you think he was able to bypass all those, what are they called? The PBMs, pharmacy benefit management?
Yeah, I think it's because from what I understand with his company, is that he doesn't take insurance, right? So he just must get like the wholesale price of the medications and do a certain markup on it and keep it at that. I think there's a shipping charge on the medications, and a lot of them are a generic, not brand name medications. So that's the kind of the sticking point, is any brand name medications, the cost is astronomical to be honest. And so a lot of the generics, we can work with that, and I do think that there's some good things on there. But yeah, it's unfortunate if you get put on a brand name medication, then that's when we have to do the workaround for Medicare patients. So yeah,
that is because sometimes if a patient starts out on a brand name medication, I don't know if you've seen this, then if you try to switch them to something cheaper like a generic, it doesn't necessarily work for them.
Yeah.
And if you're conscious, you would start them on generic.
Right. Yeah. And so it's kind of hard because we're seeing so many advancements in diabetes and in heart failure and weight loss right now. I think those are probably our biggest topics. And we have some really good meds with really good data to support them. But unfortunately, like they're all brand name right now. Like you probably see commercials for Entresto or Trulicity or Ozempic and all of those medications. There's no generic option, but they're guideline recommended. And so that's where we kind of like get into this hard struggle, at least in outpatient medicine, is like, how can we obtain those meds that we know are best for the patient when they're cost prohibitive. So
Well, and then the patients watching those commercials and they come in and tell you, well, can I just take Trulicity? And they have no
right.
idea what it
Yeah.
costs.
Yeah.
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 So
So you kind of alluded to it, Michelle, but are there different kinds of pharmacists, and does that affect the schooling that has to be done?
Yep. So I'm a big proponent of always telling my students, like when they come through, that every pharmacist is valuable and every pharmacist has an important role to play in patients' lives, because we need all kinds. So you have what we consider like your retail pharmacist. So that would be at any sort of drugstore or a supermarket or something like that. So their job is to educate patients on their meds and fill their medications, make sure there's no drug interactions. So kind of that conduit and being like the most accessible healthcare professional, because you could always come up to the counter and say, my doctor recommended this for a cold. Can you help me find it? Or what do you recommend I take for heartburn or something like that? So those are the types of pharmacists that work in that retail setting. You have your ambulatory pharmacists like me. So those are more kind of what we would call like a clinical role. So maybe that's managing blood thinners. Again, maybe it's diabetes or heart failure. We do have a lot of pharmacists that are starting to get into like hepatitis C treatments, oncology medications or psych medications. So that's an exciting kind of area of pharmacy that's really expanding right now. And then you have an inpatient setting. So that could be pharmacists that either kind of fill medications down in the pharmacy. And so their job is to review all the medications that come through from physicians that prescribe them up on the floors or advanced care providers. And then you have like clinical pharmacists that might round with an inpatient team. So you might have like a cardiology team and you'll have a pharmacist with them that is looking over the med profiles, making sure that there's no interactions or anything like that. So you kind of have those types of pharmacists as well. And then there's another area that's kind of maybe a little less talked about, is kind of managed care pharmacy. So a lot of, Chris, you had said like the PBMs. So you might have any sort of PBM or any big insurance company usually has pharmacists on staff that are helping kind of watch costs of medications, deciding which medications are going to be covered or not covered. So we call that managed care pharmacy. And so that might be an interest of certain people as well. And then kind of our last little niche is industry. So pharmacists that could work for the industries like drug manufacturers. So they could either help, with the trials, help with education. A lot of them might be called like medical science liaisons. That's kind of the fancy term for saying that they're the ones that are kind of like analyzing some of the data and presenting the information. So there's a lot of wide varieties. And that's kind of one reason why I went into pharmacy to begin with, because I knew that like once I got my degree, there's a lot of different ways I could go depending on where I found my love. And I found it within teaching and within the face-to-face with patients. And so that's where I belong. But again, every pharmacist is really important because we need all of those pharmacists. So I encourage students to really just like find their love and find where they want to be and then just go with it, because everybody has an important job. So yeah.
Well, that's really good. Thanks for sharing that, because I think people just think that pharmacists stand behind the counter and count pills.
Right. Yeah.
And there's
Yeah.
so much more to it.
Yeah.
So.
That's kind of the perception, don't you think, that people have? And it's basically, it's just from growing up. Like you go to the pharmacy and pick up a prescription, and 30 years ago, you didn't have mail order prescriptions. You went to the pharmacy. I don't think people were on as many drugs as they are now either. But do you think it's important for a pharmacist to know all drugs?
Yeah, so that's hard, because I don't know all drugs either. And so I think we have good resources. So I think part of it is just knowing how to look it up too. So looking up where your weaknesses might be and at least acknowledging when you don't know something. And so that's, I think, again, what we do really good here in the residency is just letting everybody know that we are all still learners, because there's new information coming out all the time. There are new drugs coming out all the time or new studies coming out. And so to be able to comprehend all that, like, there's just not enough hours in the day for it. So we have good resources that we can look up things, look up drug interactions. But the more familiar you become with like your routine medications, the easier it is to just like know. So I feel like once you get into practice for enough time, you can do an easier profile review. But it's okay. I mean, there's still meds I see once in a blue moon that I always have to look up every time I see it come through because it's just not frequently prescribed or it's very specialty med. So yeah.
I figured out when I was working with practices that like if it was a RIX, it was a child's vaccine, or if it was a VISC, it's an injection, a joint injection usually. So sometimes they make it a little easier for you.
Yeah.
And combine.
Yep, absolutely.
How important is medication reconciliation?
Yeah, so that's huge. And I feel like that's a hot topic no matter where we go or what conference I go to or what seminar I listen to. It's always about the med rec or medication reconciliation. And so kind of what we mean by like a true medication reconciliation is anytime a patient goes from like one like home to a hospital or hospital to home or hospital to like an extended care facility. So making sure that anytime we're transitioning, we're doing a good med review to make sure that the patients are getting on the meds that they're supposed to be on and not being on incorrect doses or incorrect frequencies. So I know that we try to have pharmacist involvement in them, or at least maybe interns or pharmacy interns or techs like in the ERs doing those types of med recs. I know from my perspective, when patients get discharged from the hospital, our clinic always calls patients to do kind of a touch base before they come in for their visit, and we try to do a med rec at that point. So I think the big key pieces are making sure that patients know what medications they're on, and either bring your bottles to your follow-up appointments, or make sure you have a list of all your medications and that list is being updated, because that's a big key too. Is sometimes we have that list in our pocket, and then the doctor changes your dose, and then that doesn't get updated. And so making sure that anytime there is a change or anytime that something happens, whether you're moving locations, that you're always kind of writing down the meds and making sure that you're keeping track of kind of those changes, because it's really in the interest of, we tell this to the patients, like, I know it sounds like laborious to go through all of your medications every time, but it's really for your safety, because we catch things a lot where a med was not prescribed, or maybe like a common one is refills run out. So then patients think that their meds are done. I had 6 months of refills. Maybe this med is done, but that's not always the case, because maybe we want to see you again and reevaluate it. And so that's why I think it's always so important to go through those meds, even though it seems like it's time intensive. It's a really important factor for patient safety. Yeah.
What about, I'm going to shift a little bit. How about the time that a drug goes through trial or something before it is considered ready for market? Is there a standard for that?
Yeah, yep. So there's bench research, as we call it. So like, back in the lab, like that's the first start. Like a lot of it is, back at like universities or big manufacturers will kind of do like their bench research to get like the really molecule and figure out what's going on. And then after that, once they've kind of got it to the point where they can start testing it in humans, they do very small testing first, usually in like healthy individuals. And so that's mostly to find like what's the most appropriate dose and is it safe. So we look in like a small amount of healthy individuals first to test that medication. Then it moves into like a little bit of a larger group of people who actually might have that disease state. And then the final one is the biggest study that usually happens. And that's with a large number of people that have that disease versus either like your gold standard of medication or a placebo. So that's like a nothing pill or nothing injection. And so that's kind of like the biggest, most robust study is like that final phase 3 study. If you hear people mention like phase 3. So that's really your big one to look at how the efficacy is for the medication and then how the safety is for the medication. So once it kind of finishes through all of that, and that's many years and many millions of dollars that go through all of that testing, then it gets out into the public. And then what we call it after that is kind of like, the fancy term is post-marketing surveillance, or phase 4. And what that really means is we're looking for how it's working in the real world. So we want to see, are there any side effects that we didn't catch, because the trials can only be so long. So they may be 2 years, 5 years, but then once it gets out into market, it could be 7, 8, 10 years that people are on the meds. And now you start to see side effects. And so that's where it's really important that patients and providers are looking out for those sorts of things and then reporting them, because that's where we are starting to catch like maybe some random side effects that again are just happening as the drugs are getting used more or getting used longer. So that's where you might see like a new warning on certain medications or a new use for medications, because we're seeing some different things like that. So that's kind of like the long and short of it as far as like a drug approval process. And so then, they hit the market, they're brand name medications and they're out there for a while. So yeah.
And they have a patent? They have patents on those, Michelle?
Yeah, yep. So they have that manufacturer then will have like the right to make that medication for a certain period of time. Usually it's like 10 to 15 years. I don't know that there's truly a standard, but it's usually about 10 to 15 years before then it goes off patent and then it becomes generic. And then there's multiple manufacturers that can make it from there. So that's where we wait. So we wait and we're watching the time until some of these medications, our very, very frequent user ones, become generic so that the costs can go down for those medications.
What about when they change the formula to extend the patent?
Yeah, that's the thing. That's real. Or a new indication for the medication. That's another thing. I think probably the biggest example of that was inhalers. So I was taught, I guess maybe I think this is a true story, or maybe it's passed down and changed a little bit as far as like my mentors would tell me. But the inhalers, they used to be formulated with a certain like ingredient that I think was like harmed the ozone or something. And so they had to redo all of the inhalers. And so when they redid all of them to like fix what was inside of them, they got back on patent again. And that's why like it's been so many years until we can get these generic inhalers, which have been like inhalers have been around for a very long time. And a lot of them should have been generic had they not gone through that reformulation or like putting it in a new device. Like there's new ways to use the different types of inhalers to try to like get the edge again, right, on those sorts of things. So that is something, yep, that happens. So you're spot on that. Yep.
I remember a few years ago, insulin was a big one, and I don't remember how they changed the formula, but it almost seemed like they were gaming it to maintain the patent and the higher cost, and it was a big deal, and felt bad for patients that needed that medication.
Right. And now, I mean, the good news is now, at least for Medicare patients, they have that $35 cap on their insulin. So that's a plus. And in fact, I mean, we do have to sometimes maintain people on insulin because they do have that $35 cap, whereas some of the other meds are going to be more expensive than that. So I guess that eventually happened. So that was a plus. But yes, I mean, the cost of insulin was like absurd for a while where we just couldn't get it for patients. And I mean, and then right now, I guess our biggest struggle right now is a lot of back ordered medications, especially a lot of those injectable diabetes and weight loss meds are like all on back order. So I'm spending a lot of time on the phone calling around trying to find like what pharmacies have them for patients, or I'll have my student calling around because that's a big issue too. And we have to do a lot of changing for meds because we can't find them or they're not in stock. So that's a big hurdle too for drug shortages.
So you mean like the Ozempic and the Mounjaro and what's the other one?
Trulicity. Trulicity. Mm-hmm.
Yeah, well, you know what? You call those pharmacies that are kind of more rural and not as heavily trafficked. And I just learned this from someone who uses those drugs. She said, I just call around and I go to like a rural pharmacy, and like rural, I mean like out in Delta or, somewhere. And she says, usually they will have it. And that means I have to drive out there. But she said, that's just a little easier than, go all over trying to find it. So she said, you usually have more luck with those out of the way pharmacies than you have with something that's like more local.
Yeah. And a lot of it has to do with like suppliers too, because certain pharmacies use certain suppliers for their medication. So if they can't get it, then it's like a trickle down effect of all of that. So it's been a struggle. It really has been a struggle here. So yeah.
Michelle, so I got a couple questions related to what we're talking about. One is a lot of this since COVID, the shortage of medication or the back ordering that you have to do. And is it a supply chain thing? Is it not enough people to work? Is it, I don't know if you have any insight to that. And
Yeah,
then
yep,
go ahead.
I think a lot of that, at least with those medications, is the publicity of the meds and the fact that there's the weight loss medications are the same like active ingredient as the diabetes medication. So, but the diabetes meds have one brand name and then the weight loss has a different brand name. And so a lot of times people have been prescribing both to try to get them. And this creates like a massive shortage because our like inappropriately people would be prescribing the like diabetes meds for weight loss, so then that depletes the supply for our patients with diabetes, and then that's where we get stuck here. And so a lot of that I think is when like kind of when Wegovy hit the market last year, like I guess it uptick last year, that just like that's what happened right there. And so I do think that like I think with the publicity and everybody seeing it and these meds working well, and then everybody wants them, and right, so like we have direct to consumer advertising. We're one of the countries that do, and like you said, you see patients that see a med on TV, they want it, they come into their doctor, they ask for it, and that's very prevalent. And so so I think that's a big thing. But I guess as far as kind of COVID hitting, it was a struggle for COVID for sure. Because a lot of it was, we took a huge swing to telehealth. So a lot of like video calls and video conferencing for things. I know they made kind of some special rules as far as like coverage for, from insurance companies, if you could do a televisit with your doctor or your pharmacist. And then, a lot of pharmacists really, really jumped ship to either different careers or moving maybe to less like face to patient interaction jobs. That was a big thing. And then as far as like the retail setting, the pressure as far as doing immunizations, like the COVID immunizations and then flu shots and pneumonia shots that were just updated, the new pneumonia vaccines just came out, and then doing COVID testing. I mean, that put a big strain on a lot of the retail pharmacies and the pharmacists. And so, I think it's getting better. It certainly has gotten better, but I mean, we did lose a lot of people during that time to retirement or finding a different career or a different type of pharmacy. So
Unfortunately, healthcare in general lost a lot of people across the board that people just didn't want to deal with it anymore, and they didn't think it was worth it. And there's like this part of me that doesn't blame them.
Right, absolutely.
Also on a little different angle from talking about these drugs, these specific drugs, what are the benefits that you're seeing? And then does it alleviate, for instance, if someone's on Ozempic, and I don't know if that's the right one for the diabetes or if it's the other name brand, but once they start taking this, does that alleviate, and I'm thinking mostly of the type 2 diabetes patients, does it get them on a healthier track quicker, that they're able to eliminate some of the other drugs they're on? Or, what are the benefits you're seeing, and will they have to be on this forever? Or does it eventually get them to a healthier state where they eliminate most of the additional drugs they need to maintain a good living?
That's a great question. So I mean, the guidelines, the diabetes guidelines are pretty favor like these medications, and like the Jardiance and Farxiga. The Jardiance commercial, I always laugh because it's so catchy. And I have two young kids, and as soon as that commercial comes on, because it's like a musical, they go right straight to the TV and watch that commercial. And so, so those medications, I mean, really, they are great. And I feel like we have been able to get a lot of people like off of insulin, because I mean, insulin, it works, right? It works. It's absolutely replacing what we have in our own body. But by using these other medications, we know that they come with heart benefits. We know they come with kidney benefits. So we know they come with weight loss benefits and heart failure benefits. And so I think that's why they've really taken an uptick, and we've been able to get people off of insulin, which is a good thing, because insulin can run the risk of low blood sugars. It can cause weight gain. So by getting the patients off of that, we're getting them on a safer regimen and a healthier regimen for their body. So I think it does come with other lifestyle modifications too, because I notice that people say they're eating less or they don't have as much of an appetite, so they're not eating as much, cheat foods or junk foods. So I think that it's really a positive direction in diabetes management. And I guess I would be remiss if I didn't mention like those continuous glucose monitors, because that kind of relates to your question as far as like the monitors that go on like the back of your arm. And so you can have a continuous like monitor of what's going on with your blood sugar readings. But sorry what happened here, but they, as far as like that, those are really positive, like real-time feedback for the patient, because you can say, I ate something, what happens to my blood sugar? So that I think promotes a lot of lifestyle changes as far as diet changes, because I'll have people that'll be like, I just had Bob Evans before I came in to see you. And then we see their sugar line go like this, so they have an immediate response of like, yeah, maybe shouldn't have had that biscuits and gravy. But then they're like, if you have, a protein healthy meal and apples with peanut butter, and then you see it not spike as much. And they're like, okay, I know that this is good. So those, I really wish were more accessible to like all of our patients. I would love to have every patient on one of those, because that is like, has been life-changing in diet management for sure for patients. So
What about side effects from those drugs?
yeah, that's a big discussion too, because we are starting to see a little bit more side effects, as I kind of had mentioned, as far as like looking at the patients now that they're past the trials, right? So we are seeing different types of side effects and maybe more contraindications to medications as time goes on. But I guess like that's a full discussion that I feel like I always have, and I would encourage every provider and patient to ask of their providers, is to say, what are the benefits of this medication and what risks do I assume by taking this medication? So I think that that's always a good conversation to have of any new medication that you are starting, because you need to have the informed consent to know, like, is this what I want to do? Like, I know I will know the benefits. I know it will help me control my diabetes, but what are the side effects that I have to worry about? And are they insurmountable? Like some people are just like, I don't want to take that risk, or I don't want to do an injection. I'm not going to do this. Like, I don't want to. Give me something else. So that's why I think it's super important to ask those questions of your providers, and all providers should be having that discussion with their patients too.
And would you have to be on that the rest of your life?
It depends. So I wish I had a better answer to that, but I think it's really going to depend. I know a lot of diabetes, type 2 diabetes in particular, is weight management and lifestyle modification. So if you can make those and those meds help you and you get down to maybe a healthier weight, or you make really good changes to what you're doing in exercise, you can start to shed the medications. And I'm happy to do that. I love to de-escalate medications, right? Even though I'm a pharmacist, I would rather you not be on any meds if I could. So like that's a possibility, but it takes additional work, in combination with that. So yeah.
Do you see, I think we touched on it a little bit, but do you see that insurances kind of inhibit some patients from getting the medications that you would like to prescribe to them, or that they need to, get better or maintain, like a maintenance drug, even something like that?
Right. Yeah. So this is something I'm pretty passionate about talking about. And I usually kind of go through my spiel every year for Medicare patients when they're signing up for their open enrollment, but this kind of pertains to just about everybody too. So I think the best thing to kind of go back to basics as far as like insurance companies, they have what we call like a formulary. So they decide what medications that they're going to cover and not cover. So there are certain medications that like you have to cover, and you have to cover at least one in every class kind of thing. But they kind of will make decisions as far as like, am I going to cover Trulicity or Ozempic or both? And so that's kind of where it starts at that piece there. Manufacturers, they charge what they charge for the meds. That's going to be what it's going to be. And so between that, then like your insurance company can decide on a copay for the medications. So the big kind of take home points that I always try to talk to patients about is copay cards. So copay cards are a great way to save some money. They're sponsored by the manufacturer, but they're used kind of like insurance. So you have to have a commercial insurance, or like we say working person's insurance or marketplace insurance. And then you can just Google any brand name medication like Trulicity copay card or Jardiance copay card, and just Google that and it'll take you right to the page. And that gets the cost of your medication down. So they kind of run your insurance, then they run your copay card. That'll bring down the cost of your medications. And so again, that is just for like your commercial or your working person's insurance or your marketplace insurance. Where we get into a little bit stickier situation is our Medicare patients and when they hit the donut hole. So that's always a big topic of like, my medication cost me, $40 a month. And then all of a sudden it hit June and now it's $120 a month. And like, why did this happen? And I don't understand. And so that's the donut hole piece right there. And so we're limited as far as options for Medicare patients for medication affordability because you can't use those copay cards. So what we end up doing and what a lot of what I do is patient assistance. And so that's a really great option because it's based off of income. So whatever your Medicare patient's income is. So a lot of times it's a Social Security check every month. And so that usually meets the income requirements or well below the income requirements from the manufacturer. So as long as the patient fills out the form, the physician fills out the form for the medication, again, brand name medications, then faxes it in. And then if they meet the requirements, they'll get the medication for free for the whole year or for the calendar year, I should say. So if you start in June, it goes till the end of the year. So that's a lot of what we do for our expensive diabetes meds or our heart failure medications is filling out a lot of patient assistance for them. And it's great because, the Medicare patients are often on a fixed income. They're retired. They don't have working person's insurance anymore. And so when they hit those high copays in the middle of the year or towards the end of the year, then by doing this, we can get them their medications for free. So that's a really great option and a cost saver for them.
Well, a question on the copay cards. If you're a working person and you're trying to get a copay card because let's say your drug coverage through your healthcare benefit is not that great, is there income requirements for that, or can you just anybody can apply and get that?
Yep. No income requirements. And so usually they'll take off like a maximum of like $150 from the cost of the copay, but down to like somewhere between $0 to $25 for the cost of your medication. So I encourage everybody to use it. So I'm like, it'll save you some money. Like I'd pay for, groceries for the week or whatever, so go ahead and go Google them and get your copay cards and use them. So, yeah.
So the Medicare, when you're in the donut hole and you're trying to get assistance for medication, that's a little more cumbersome, isn't it? Don't you have to submit like your tax return
So sometimes a few years ago they were very, very stringent on what like documents you had to submit. Now some of them can do just like I don't know if it's a credit check or something on the back end where they like run it on the back end to see. So you don't actually have to like submit documents anymore. Some of them do require, it's just all manufacturer specific, but yeah. So, I forgot to mention inhalers too, because inhalers are quite expensive. So I do have a number of patients that, again, it's a lot of diabetes meds and heart failure meds, but then inhalers too. So yeah, but that has to be, so I guess the take home point on that is if patients are interested in doing that or they're listening to me talk about that, the forms are online. You can get the forms online, but also your provider should know how to fill those forms out because it is going to require a physician or a provider's signature on it, as well as the patient's signature in order to get those to go through. And sometimes they'll ship the medications to the doctor's office or sometimes they'll ship them right to your home. So it's really nice. And I think it's changed lives for patients. Like I get thank you letters as far as like, I would never be able to afford this. Thank you so much for helping me do this. And so, I think that's a little known secret that a lot of people just don't know about or don't explore, but it's out there. So.
Well, I wonder if it's always verbally communicated to patients at the provider level.
Mm-hmm. Yeah. And I do I whenever I do like my senior center talks or like nursing home talks, I always tell patients, or even here when I'm helping, like I don't prescribe the meds, but when I'm helping to do that, I always say, like, if you get to the pharmacy and it is too expensive, you have to call us. Please call us because there are options. Like, I don't want you to just not pick up that medication. And then a month from now, you come into the office and nothing has changed. So like please call me. Like I will help. I'll do my best to help from that standpoint. So I always tell people to do that. Like call back your provider, please, and let them know that you're not picking it up because of cost, because we can try our best to work around it. Again, we can't always work miracles, but we can really try to utilize all of our resources that we can to do that. So I'd rather you bug us if you think it's bugging, but I'd rather you bug us and let us know rather than just, not taking your medication.
Good point.
I think that right there is worth its weight in gold, that information, sharing that information with people, because I think a lot of us that have benefits, pharmacy benefits, didn't realize that we still could benefit from like those copay cards. So
Mm-hmm. Yeah.
That's fantastic.
Yeah. And I guess my
Yes.
last kind of like, I mean, not my last plug, but my other thing that I always do recommend, and again, I feel like I've done a lot of talks on Medicare, but is when you get to that open enrollment period at the end of the year, which is like October or whatever, like Medicare.gov's website is really great. And I say go to that website. I did this for my parents. You put in your medications that you're on, and then it'll map out the whole year for you. So it'll map out what your premium is going to be for the year, what your med costs will be for the year. And so I always say, please do that, because then you'll know what to expect for that year coming forward, especially when picking a plan, as far as like, are you going to have a really big deductible at the beginning of the year, or are you going to have no deductible and pay a little bit more each month? So I think that that's helpful for like budgeting purposes too, because we get a lot of calls too in January that's like, hey, I got a $500 deductible. And so my, inhaler is $500 for my first fill. I can't pay that. So if we maybe picked a different plan, or you looked at a different plan, you can kind of see like what's manageable for your budget for the year. So every year it's a good idea to just put your medications into that website. It's, Medicare.gov, and then go through and kind of look at your plan for the year as far as which Medicaid or which like Part D plan or your managed plan is going to be best for you and your lifestyle.
That's good to know. Someone has to be astute enough to be able to do that.
Mm-hmm. Yeah. So I try, like, even sometimes like during my Medicare annual wellness visits that I do with patients, I'll just like show them that and like walk them through it a little bit and say like, play around with this, but this is how I would like for you to do this. If you have access to the internet, I always ask that first, you have access to the internet, to make sure that they like have the ability to even do that. So yeah, that's a good point. Yep.
Well, even like for my insurance, I'm on a commercial insurance, but we have an HSA. So we pay for everything, even our drugs. They're all, everything goes to the deductible for the first $5,000. So and a lot of people have this type of plan.
Mm-hmm.
And so knowing that there's an option out there with like for a copay assistance, we just paid $672 for Advair.
Yeah. Oh my gosh. Yeah, I know. Yeah.
Yeah.
It's a car payment or part of a mortgage payment
I
or
know.
something.
Thank you. Exactly.
Yeah.
Yeah.
So
And I mean, I wish I could recall the statistics, because I haven't done this talk in a while, but it's like an alarming number of people that have either like not taking their medications every day, or like fixing the dosing, instead of doing like 2 puffs twice a day, doing 1 puff twice a day of their Symbicort or something like that, just to like make their medications last longer, or having to like cut back on like food or groceries or something like that in order to afford it. I mean, I wish I could remember the exact number, but I mean, it's like it's astounding to like know how big of a strain that can be on patients.
for sure.
I don't want to really pimp any specific pharmacy, but I just know this through a family member. Kroger does have a program where I think you pay $30 and they give you that pharmacy card. Are you familiar with that?
Yeah. So I have recommended that to some patients before. Yeah, it's called like, I think, the Kroger savings plan or something like that. And it's a one-time fee. Then they have like smaller copays on their medications, and that runs outside of like insurance. They don't run that through insurance. So
right.
Yeah, so that's an option. And then like, I mean, you've seen like the GoodRx cards or the OptumRx cards or all those ones. But again, that's really only for generics. It's not going to help you on any brand name medications. It might get the cost down for some generic medications, but not for your brand name meds.
Oh, so GoodRx is only for generic?
Yeah. So.
Wow. Well, that's good to know.
Yeah.
Mhm.
So is there anything new or interesting in the disease state that you've seen in the last few months?
Yeah. I mean, I kind of talked about diabetes a little bit, but I mean, I think there's been a lot of really cool things with heart failure lately. They kind of did a revamp of the heart failure guidelines a couple of years ago, but we have new meds like that Entresto, and a lot of some of the diabetes meds can double down on heart failure as well. And so I think we're seeing like really amazing things with heart failure in particular, which is really exciting, because there used to be we just had our old standbys before. And so now we've got these new meds that are really working well, at least to prevent like admissions to the hospital for heart failure and those sorts of things. But yeah, so that's pretty big. And then, the oncology world is always bustling as far as new medications being approved for, relapsed certain cancers and things like that. But I guess what I probably see most is the more I mean, I'm not in an oncology clinic, but I see more on that standpoint. But yeah, so I think those are the big things. And then, the weight loss market out there is really booming as well. But yeah, I mean, there's always new drugs. I have my FDA, I subscribe to the FDA email thing that every time a new medication comes out, I get an email about it to make sure that at least I'm trying to stay up to date. So on those kinds of meds, and yeah.
Well, that's good. This has been really good, Michelle. I mean,
it's been great.
I've learned a few things, so I appreciate your time and your willingness to talk to us. And that's really helpful, especially on copays. So, Carrie, do you have any additional questions?
No, I think she covered everything. Plus,
Yeah.
I really learned a lot this time. So I really appreciate the time you spent with us and informing our viewers as well. So
Happy to do it. Absolutely.
Yeah, thank you so much. So with that, we're going to close, but we appreciate your time, Michelle.
Thank you.